4, 3, 2, 1. We are live. Good evening, everyone. We welcome you all to OrthoTV, Episode 3, Young Surgeons Forum on Arthroplasty. To introduce today's topic and the speakers and presenters, I hand over to the convener, Dr. Anoop Dhamangaonkar.
Good evening. Thank you, Dr. Neeraj Bijlani, sir. So today we have amongst us for the third module, a man who does not require any introduction, the Master of Masters, Dr. Rajgopal, sir. We really appreciate you giving your precious time to us. And today's theme is basically how do we perform TKR in a Varus, which is pretty much a bread and butter case for most of the cases of surgeons in India. And we would want to hear from you, sir. From your decades of experience being collated down to about 45 minutes will be really appreciated. So please go on, sir. And for the case presentation today, we've got three eminent surgeons, Dr. Abhishek Patil from Pune, Dr. Jayesh Baviskar from Mumbai, and Dr. Sameep Sohoni from Mumbai. Okay, so Dr. Ashok Rajgopal, sir, all over to you. We are keen to hear your talk.
Thank you, Anoop, and thank you, Neeraj. Thank you, Jay. It's as always, it's a real pleasure to join this meeting virtually. Can you see my slides?
Yes, we can.
Okay.
We can.
Right. So first up, greetings to all of you from Delhi. We hope that the next few months we will be actually able to see each other in person and have more active interactions. So I was asked to present on my philosophies of principles of total knee replacement in the Varus knee. So we'll walk through this this presentation. It's followed by a very short 7-8 minute video, and then we'll be happy to try and take any questions. These are my disclosures. So this is typically like Anoop mentioned, the bread and butter of osteoarthritis in most parts of the world, indeed. And it accounts for almost about 85 to 90% of all presentations of the arthritic knee. And they come in different sizes, shapes, dimensions, extents of deformities, from very mild, subtle to absolutely gross, like you see on these x-rays. So when we see a Varus deformity in our mind, I think the easiest way to start is to try and stage these deformities. Now, this is very arbitrary. There are various classifications which we are not really going to go into. The most recent actually is the one by Dr. Pavisi and Emmanuel Thinpont. And I'm very happy to actually say that Vaibhav has joined hands with these two stalwarts. And I was talking to him a few days ago that they have actually modified Vaibhav's contribution to this deformity classification has been accepted in the American Bone Joint Journal. So very, very creditable. And I think we are very, very proud that one amongst us has been privileged enough to have done this classification. So I don't know if Vaibhav is linked on, but congratulations to this wonderful person. So the easiest way to classify this is mild, moderate, and severe. Again, these numbers are very arbitrary, but 10 to 15 degrees is mild. In the West, 10 to 15 would be gross and severe. So, but we're talking in the context of the Indian subcontinent. 15, 20, 25 is moderate, and more than 30 is severe. And we do, surprisingly enough, at times see deformities that are in excess of 50 degrees, patients not being able to stand up, completely subluxed knees. And when we operate on these patients, the fundamental issue is understanding the pathology of the contracted tissues. Now, when we look at a severe Varus deformity, I'm talking of more than 20, 25 degrees. The structures that are contracted are the deep MCL, the PES, there are marginal osteophytes, the posterior medial capsule is contracted. PCL is debatable. Some people would say it is. Those of us who are CR surgeons would disagree with that. There is almost always a posterior osteophyte. The semimembranosus insertion is shortened. And in very, very severe cases, you might have contraction of the medial superficial collateral ligament. Now, when we embark on surgeries, uh, the critical issue is you need to understand that all of these need to be released sequentially. And after each release, you check the adequacy of correction. And I would put a word of caution that your superficial medial collateral, if at all possible, should be the last or not released at all, because this can cause major medial or posteromedial instability. So the challenges in management, particularly with severe deformities, is multifactorial. You need to manage instability, bone loss. You have to obviously restore the alignment, balance, reflection, and extension spaces. And in severe deformities, you need to have a considerable inventory available to you that gives you the options of augments, constraints, and stems to be able to balance your knees adequately. So in terms of the management algorithm, the first thing is your deformity fixed or flexible or correctable? Is there an associated bone loss? Oftentimes in severe varus deformities, you can have extra-articular deformities. So is your deformity intra-articular, peri-articular, or extra-articular? And finally, the issue of constraint, how much is enough, how much is needed, and what the extent of restraint do you want for these very severely deformed knees. So operative details, certainly in our mind, we do a soft tissue release as part of the exposure. And before we start to do any bony cuts, we like to try to correct as much of the deformity as possible. So our approach is also our soft tissue release, and this includes removing the osteophytes to attain 75, maybe 80% of the deformity correction. We are great advocates of using an anterior referencing system, and we'll go into that in a short while. Why we say that? The more severe the deformity, use more conservative bone resections, particularly on the tibial side. And where there is bone defects, there is a whole host of options available. And I can only say they all work, but bone grafts are arguably one of the finest ways to reconstruct bone defects. You are adding bone, and in some of these deformities, severe deformities, the reported incidence of aseptic loosening and failures of these implants is reasonably high, as high. Some series report up to about 8 to 10%. So if you're reconstructing bone, it gives the second surgery a chance of not having to go on to metal augments. And finally, the philosophy that we embrace for all knee surgeries: use the minimum constraint to achieve stability. So we look at the medial release, and we start with the deep MCL, the medial capsule, remove all the osteophytes. We go up to the semimembranosus tendon, and we release the posteromedial corner. Now, again, different surgeons have different approaches. This is not one of my own intraoperative surgical pictures. We do not use Hohmann retractors, but this is done by a colleague of mine who uses these, and what he's demonstrating is the posteromedial release and the semimembranosus. So in terms of the surgical technique, uh, because a lot of these these various deformities are associated with flexion contractures. So you want to release your posterior capsule, and even deformities up to about 25, 30 degrees, you can release the capsule, and removing these posterior osteophytes as you see over here, and recreating your posterior recess will oftentimes correct both your varus and your flexion contracture. Resecting the distal femur, yes, it is a described technique. You can go up to 2 millimeters safely, but the minute you start exceeding 2 millimeters, remember, you're opening yourself up to the risk of a flexion unstable knee. Flexion instability is particularly common when there is a major release and major combined resection of the distal femur. So what is acceptable in terms of once you have done your surgical procedure and you've done your trials, when do you say that your knee is balanced? So you need to have about 1 to 2 millimeters of opening of the medial side, and we're talking now of about 10 degrees of flexion. 2 to 3 millimeters on the lateral side. So your lateral side needs to be just that little bit more sloppy as compared to the medial side. And if you are a CR surgeon, as we are, you want to make sure that the femur articulates to the middle third of the tibia, as you can see over here. So this is the next gen system. This is one of my very old slides, and they have these 3 lines. So those of you who are using other systems, you can figure out a way. But basically, what you're really trying to do is to make sure that your tibial base plate and the medial condyle of the femur and the tibia are coapted well, and the tibia is not anterior or posterior relative to the femoral component. Again, when you deal with severe deformities and you do your tibial resections, try not to go to the base of the tibia, so which really means that your tibial cuts will almost always be incongruous, as you see over here. Again, those of us who are CR surgeons, just a word, you always need to go back into the intercondyle notch and remove all the osteophytes. And these can be released using a very sharp, narrow osteotome so you don't damage the PCL. And that's a good place to start to balance your PCL ligament. Now we come to the issue of the posterior condylar overgrowth. We mentioned a little while ago that we are anterior references, and the reason for that is when you have a severe varus deformity with the medial tibial condylar defect, there is almost always a compensatory overgrowth on the posterior medial condyle of the femur, and consequently, if you are using posterior instruments with paddles on the posterior condyles of the femur, it will tip your cutting block into internal rotation, and you'll get an internally rotated femur, which is not what we would desire. So anterior referencing is always the way to go, certainly in our minds. Another contentious topic that we believe a lot in fact, we have just reported this and we've sent it for publication. In patients with varus subluxation, particularly the type that you see in these very horrific varus deformities, in addition to your medial release, surprise, surprise, you need to release the posterolateral corner. So we have our own classification of the varus knee, and these subluxed knees and knees that are externally rotated, they have a contracture of the posterolateral capsule. So you need to release that posterolateral corner, and this will tweak it back, and you can get good correction without using CCK or TC3 type of an option. As I said, anything that is more than 20 degrees of fixed flexion deformities, several authors have reported using the PCL, resecting it, substituting it. We've consistently believed that you can recess the PCL. So even in very severe deformities, we have used the CR with very gratifying results in long-term survivorship upwards of 15 years. In terms of managing deformities, bone loss, there are several methods. You see a couple of them here. This is a bone graft that we used. This is something which is our go-to option. Sometimes the defect is too large, and the bone defect lends itself to use with either a wedge or a block. Of the two, the wedge is the better option because when you have to use a block, you have to take away additional bone. But our experience with the bone grafts has been phenomenally good, and they have almost like 100% take-up rate. And at some future point in time with these deformities, should the knee loosen aseptically or otherwise, the next surgeon or you yourself have a good bone stock to play with. So always try and use autogenous bone grafts. In terms of constraints, sometimes you will get these very severe deformities which are fixed, and no matter what you do, what amount of release you do, these deformities are difficult to correct. And very rarely, extremely severe deformities like these, you sometimes might need to go all the way in terms of the constraint option and go to a rotating hinge. Again, the issue of constraint, you can see over here, the three options. You can do a CR, you can do a PS, you can go to a LCCK, very severe deformity. And if you have complete global instability, that you see sometimes in neglected rheumatoids, we've oftentimes used a RHK as well. A lot of talk about MCL pie crusting, medial epicondylar osteotomy. Several authors, several of our friends have reported this. We shy away from this. Our very firm belief is MCL is your major stabilizer. It is your critical ligament as far as I'm concerned. There are several authors who have reported adverse results with releases, particularly when it's performed in flexion. And you get a very uncontrolled lengthening of the medial collateral ligament. It scares me to use knives, but authors have reported good results using pie crusting, using needles. We've never ever done this. We have not done epicondylar osteotomies because we just believe that no matter how bad the deformity is, you can get away without touching the medial complex. So again, in terms of the medial epicondylar osteotomy, these are some of the articles in literature. Leo Whiteside and Mialko, they've done phenomenal amount of work, and several authors, in fact, question the role of a medial epicondylar osteotomy in these various knees because it produces significant laxity in this group. So our preferred algorithm is in mild to moderate deformities, we'll go to a cruciate. Most of our severe deformities, we would do a cruciate retaining, but if for any reason we are not able to balance after an adequate release or the PCL is attenuated, we would go to a PS option. When there is a concomitant fixed flexion deformity, we would prefer doing a PS or an SCCK if there's a flexion instability that cannot be dealt with by a PS implant. Our go-to option for a bone loss is to use a bone graft with screw fixation. And when we do screw fixation, always we use a stem augmentation. And we use augments only if the defect is massive. So our considered opinion is that most, I would say 85, 90, 95% of various knees can be corrected using CR options as long as you remove all marginal and posterior osteophytes, the intercolumnar notch is cleared and the PCL is well balanced. In deformities with huge amounts of bone loss and growth instability, varying degrees of constraint may be needed, going up to either an LCCK or an RHK type of an option. We've also had experience of using robotics in the Varus knee. We've had experience with the Navius system. So this is basically a stress view. I'm sure you're all aware of this. So we go from a preoperative 11 degrees in this case to a postoperative 0 degrees. And basically what you're really looking at are these graphs where excessive medial tightness is shown in red and the lateral compartment laxity in blue. So we collect the pre-op and the post-op baselines, and you then go through this graph, and this is really one of the older systems. Now we have more advanced systems where you can actually see the rollback, but roughly at the end of the surgery, this is the kind of graph that you want, the blue lines on top. You don't want anything below that horizontal line. So this is a patient who had a preoperative alignment of 11 degrees of Varus, and the planned was total correction, which was achieved. Some examples, preoperative x-rays. This is a CR knee, 11 years post-op. You can see excellent alignment and excellent function. This is a patient who had a CR with a stem because of the large defect. 11-year follow-up with a scanogram with restoration of the alignment. This is a patient with very, very gross Varus deformity. You can see huge amounts of bone loss. Again, a rheumatoid, secondary osteoarthritis. There's no way you could use conventional primary implants. So this patient ended up with a rotating hinge and has done well. So in conclusion, I would not like to spend too much time debating the merits or demerits of the CR or the PS. I think all over the globe we have achieved consensus that both work well. It depends on your training, your bias, your beliefs. If you do choose to do the CR, do it the right way. PS functions just as well. In fact, we've just published an article in the IGO, a 15-year follow-up of CR and PS in the young patient, and both have excellent results. So the CR seem to function somewhat better. And the only point I would like to sort of put on the table here, again open to debate and questions, is typically you're taught that CR is not for severe deformities. We would sort of beg to differ from that. Very severe deformities like what you saw in some of my earlier slides lend themselves to CR. You need to sort of be able to handle it. And obviously when there is gross deformity and bone loss and instability, you would need to go to more constrained options. So we'd like to now quickly run through the video. So this is one of my own videos. This is it's obviously an edited video. It's I think about 7.5, 8 minutes. And this is a Varus deformity, weight-bearing x-rays. We use a vertical midline incision, as I'm sure all of you do. Medial parapatellar arthrotomy. We do a medial release. As I said, our soft tissue release is a part of our exposure. We then remove the intercondylar osteophytes, and we make a big deal about this because you want to decompress that PCL. Because as you're flexing it, if you don't remove these osteophytes, you can actually avulse the PCL. And those of us who believe retaining the PCL is a religion, we go this route. This is the white side line and the transepicondylar axis. We also believe that your orientation in terms of rotation should be not single plane, use multiple landmarks. This is the persona system. I'm sure some of you or all of you are familiar with it. This is the distal resection first option, and you have a choice of, you can bevel a plus cut up to 4 millimeters in this. So in this particular case, we use these pins. In case you have to distalize it or proximalize it, you can do it. You do your distal cut first. You typically remove about 9 millimeters of distal bone. Once you've done that, you remove the meniscus and try and clear it up. This is your sizer. And these are anterior instrumentation. This is the femoral completion block, femoral finishing block, very robust in its morphology. You can look through and see the bones. And there are several safety checks that are available in these instruments. And it just helps you to do your femoral cut very, very rapidly. It doesn't take more than about 35, 40 seconds to complete your femoral cut. So once you've done that, you remove the intercondylar osteophytes and the posterior osteophytes. And you can see over here, this is what we're trying to do. There's this intercondylar osteophyte, which will dent your PCL. So you want to try and remove that. And you also remove the posterior osteophyte, as you can see over here. So between the two, you have decompressed your PCL very nicely. And in this case, we have also taken out, we have done our tibial resection. So as I said, this is an edited version, and any posterior osteophytes, loose bodies, you can try and remove it at this stage to be able to decompress the so the posteromedial soft tissue release is very, very important for us. Some of the modern techniques actually speak about not releasing soft tissues. Doesn't really go down my throat. I don't really understand not releasing soft tissues. I'm still sort of old school. Several of the masters, people like John Insall, Dr. Ranawat, we all, I think I come almost in that vintage, maybe a few years later than them, but we still believe that this is the best option, the best way to do it. Again, you take your depth resection guide 2 millimeters from the defect side or 10 millimeters from the intact side. As I said, in severe deformities, this rule does not apply. So you take out, it's not 10 millimeters, you take out 6 to 7 millimeters. That will usually do. And one of the other things that we do, which is probably strange and you'll find it rather odd, we don't use Hohmann retractors at all. You can see we get very, very good exposure just by doing soft tissue releases and handling the position of the knee. You get excellent visualization of the entire tibia. You can actually sublux it without putting those spikes in. It just scares me, it worries me. And I may be wrong, but I think, when you yank the tibia out, there is a certain amount of stretch on the posterior capsule that may account for pain. You then size your tibia, and we believe this is the best way to do it, on the resected surface. And we don't use spacer blocks, we use the trial implants as our spacers. So we start with a 10 millimeter option. The nice thing about the Persona system, I think this is also available in the Journey, and I believe the Tune as well. You get 1 millimeter increments. So that's really very, very nice. I think that's the one thing that these newer generation implants have brought us the comfort level that you can really fine tune these 1 millimeter options. You're seeing here that this knee was a little loose. From a 10, you want to shift up to 11. You don't have to remove this whole implant. This is what is called a shim. There are two tables of the trial. You go from the neutral to 1 millimeter, and you're on to 11 millimeters. So it's very quick, very elegant, and you can balance out the knee very, very nicely. So that is pretty much the procedure. The rest of it, of course, is the routine lavage, wash, drill holes into the resected surfaces, and then the cementation. And just one quick word before we wind this up. You must check stability. You can see the PCL beautifully over there. Check your stability in 5 degrees reflection, 25, 6, 30, 60, 90, 120. Make sure that your knee is stable right the way through. The other point I'd just like to mention is people always ask me, how do you understand your rotation? We've actually published on this quite extensively. Just match the anterolateral curvature of the tibia of your patient with the anterolateral curvature of the trial. Just do that. And if you do that, you're making it native or anatomical to that particular tibia. All these Agaki lines, medial third of tibial tubercle, is very, very hard because it's a very debatable sort of issue. So this is what we have done, what we do always: multiple drill holes for cement penetration, thorough lavage, and then we do our cementation and closure. So with that, I'd like to stop, and I would like to thank Ski and all of you for your patient hearing, and be very, very happy to answer any questions that you may have. Any comments? I'd be interested in knowing your points of view, especially your points of disagreement, if I may. So be very happy to try and discuss this.
Thank you very
Right,
much. This was a great presentation as always. Just a few points, sir. You did mention that you don't use any spikes to sublux the tibia forward. So do you actually ask someone to push the femur down and that itself brings it forward, or is just the release?
No, so I think you're absolutely right, Jeb. When you hyperflex it and you push down on the femurs, pops the tibia forward, and that just allows for, and once you've done your release, particularly up to the semimembranosus tendon, you're able to, and the other real tip is not to evert the patella, but to just keep it vertical and dump it into the lateral gutter. That does not stretch your patellar tendon, and it allows for the whole tibia to move medially and anteriorly, and you're able to visualize the tibia very, very beautifully. The exception would be a very obese patient where we really struggle, but that you would struggle in any case. So we try, I mean, as one of the things I must confess is when I started doing knee replacements, we hardly had any instruments. We didn't have the benefit of all these wonderful tools and instrumentation systems. So we grew up really with what we had, and over the years we just developed this technique, which we've never really regretted not using the Homan retractors.
But is there any circumstances in which, if you are even after doing a complete release and hyperflexing, you are still not able to deliver the tibia sufficiently forward? Would you use a spike, or what is the point where you feel that that you're not happy with the amount the tibia has come forward?
Yeah. So for the exact reasons that you mentioned, some knees are very, very stiff. Some soft tissues are very, very robust and rigid. Patients who are very obese, in those cases, we will use a Homan, but what we do is we put a gauze around the tip of the Homan so that we're able to sort of gently sort of subluxate it. One of the things that happens is the guy who you are handing the Homan retractor to is usually the most bored assistant on one side. He's really waiting for you to say, okay, case over, let's get the hell out of here. He's usually standing to your right. He can barely see what you're doing. And all in all, he's one guy, you want him happy. So, and oftentimes what happens is his mind is somewhere else, and that spike pops out and, either into the tibia or the popliteus tendon goes off. So that scares the hell out of me. So, if I must have used this in a total of about 15, 20 times. And each time I keep nudging him with my elbow, to make sure that he's on the same page as me, just to make sure that, we're not messing up or screwing up on the neurovascular bundle. But most times you can do this without the spike quite efficiently.
Hello, Dr. Abhishek, yeah, go on.
Yeah. So 2 questions. Do you release the semi-membranosus as a part of your exposure, or at what point do you consider releasing the semi-membranosus? And second, at what what is your indication of doing a reduction osteotomy?
So, okay, great questions, Abhishek. So if it is a severe deformity, so you've gone from the anterior side, you've released the deep capsule, you've taken out the meniscus, you've gone through the meniscofemoral ligament, and you go up to the semimembranosus tendon. At that stage, you check manually, do a serial release, you do a correction, and then you check. If you still find that you're not able to release, you're not able to correct the deformity, in that case, you start with very selective semimembranosus release. Do it very, very sequentially. We use a cautery and release it bit by bit. And at that point of time, you choose to size your tibia. If you're using a symmetric tibia, like you have for the next gen system, so in a symmetric tibia, almost always in severe deformities, you will need to do a reduction osteotomy. With an anatomic tibia like you have with the Persona knee system, the adaptation of the medial and lateral side is so good that your reduction osteotomy gets reduced to 10%, 12%, 15%. And if after the reduction osteotomy and your selective release, you're still not able to correct the deformity, then you go all the way back. And if even that does not release the deformity, then you might consider releasing the PCL and going to a PS type of a knee.
Okay. So one question more. You have already spoken on this, and you have said very categorically that soft tissue release is an integral part of deformity correction. But I also follow that. I also agree with that. But there is a generation of surgeons now, especially the robotic ones, who argue saying that soft tissue release is the major cause of pain post-operatively. And if you can compensate the deformity by doing a bony cut and not touching the soft tissues, the patients are more comfortable. So I wanted to know your opinion on this particular argument.
So Abhishek, again a great question. What I would respond to that. There is a lovely article in June 2020 on in the Journal of Arthroplasty, where there is the author. It's a group of authors who have done systematic reviews and meta-analysis of 425 different aspects of knee replacement, and one of them obviously is robotic. And every point that you mentioned has actually been challenged there. Less pain, maybe for the first 24 hours, first 48 hours. Quicker recovery, no. Better long-term outcomes, short-term outcomes, yes, they're definitely better. I mean, that we have seen that as well in our experience. We've been doing the Navio for about 3-4 years. But if you review these patients at 6 months and 12 months, they're exactly the same. Do they reduce outliers? Yes, they do. But then so did navigation. Navigation also supposedly reduced outliers, but did it improve outcomes? Did it improve survivorship? It did not. And the case in question, Abhishek, is if these technologies were as good as they were made out to be, in 2010, the incidence of navigators was as high as 23%. Today, it is 2 to 3%. Why has the numbers fallen? Why have the numbers fallen? I mean, and if you look at navigation and robotics, it's really an extrapolation or an extension of the same system. I mean, none of the systems that you have are true robotic this thing.
Yeah.
To your point, you cut the bone to adapt to the deformity is unphysiological. When you look at the kinematic alignment itself,
Exactly.
You cannot. You can slope your tibia any which way. Again, I was on a debate at CCGR with the great man himself, and yeah, and we agreed to disagree because he quoted 8 references in favor of, and I produced 12 against better outcomes with kinematic alignment. So there are various ways to skin the cat, and my sense is if you can do it the conventional way. And again, in the same article, there is an editorial by John Callahan and Michael Mont and Javad Parvizi and so on, where they say, is every progress the right progress? I think we need to wait another 5 years at least before we can say that, yes, this alignment of kinematics is better than mechanical alignment. When you look at the latest issue of JOA, which is the July 2021, the AAOS has published what the various members of the AAOS do. 79% of all surgeons doing knee replacements use the mechanical alignment. Now, there's got to be some merit, some weightage. Why 79% are still doing this? This is an open survey. And only about 11 or 12% or 13%, if my memory serves me right, are doing kinematic. To answer your question finally, Abhishek, my belief is, I agree, our knees, your knee, my knee, Jay's knee, we are all in Varus. There's no question about it. For me, the most physiological and the right way of doing a knee is to cut the tibia at right angles and to use the principle that Johann Bellemans introduced in his journey knee, where there is a slope in the articular surface. So we are actually in the process of doing a multi-center trial. That makes sense to me, but that again is a soft tissue release. So for me, as long as I do knees and I understand knees, I will continue to release. There are people who would sort of take the opposite camp, and that's fine. I think time will tell. But for me, 30 years, we have survivorship of 30 years now. My own patients that we did in 1991 are still going strong. I can't say I have 100 of them, but we still have 5, 7, 8 patients who are still doing that. So, I mean, at the end of it, there are 10 different ways you can do knees. They're all right. And as long as you can deliver, your patients are happy, you relieve them of the pain, they get a functional of 0 to 115 range of weight bearing flexion, and they're able to do 8 out of 10 things in their life. I think you're on a good place. Yeah.
Yes.
So just one question in stiff varus knees, when your extension gap is balanced and flexion gap, you still find your middle compartment is pretty much tight. You've done your posterior release, you've externally rotated your component by maybe 5 or 6 degrees, 5 or 7 degrees parallel to your tibial cut, and still you have lateral laxity, especially in flexion. What would be your option in that particular position?
Okay, so again, great question. I'll tell you in yesterday's context, and I'll tell you in today's context. If you were to ask me this question about 4 years ago, I would go increase my constraint. I would upsize my femur. If I was using a size 2, I would go to a 3. I would increase my flexion gap, make sure my flexion gap. For me, the most important two things are the integrity of the medial collateral ligament and a stable flexion gap. So I do all my knees, even primary knees, the way I do my revision knees, which means securing your flexion gap. Again, something that I have maintained and got into a lot of very heated arguments with my very esteemed colleagues. When I stick my neck out and say any patient who flexes more than 120 or 125 degrees is flexion unstable. You cannot flex beyond that. And a lot of my very, very accomplished colleagues say that's wrong. And I love the debate with that. But that is the truth. And the proof of the pudding is, again, in this July 21 GOA journal, there's a report by Doug Dennis and Rick Comistag, where they have done actual fluoroscopy studies in patients who are hyperflexing at 130, 135 degrees, and they're all subluxating at the point beyond, because your dwell point is going backwards. It's no longer a medial pivot, it's a straight posterior shift. So you're actually going back. So when you're bending the knee, it's actually sliding back. Yeah. So, and that was one of the biggest criticism and failure modes of the Journey 1. It was flexing so much that it was not able to climb back on. And that is really what was changed. That cam and post mechanism, anterior and posterior cam was changed. That was the difference between Journey 1 and Journey 2. And a lot of the knees were flexing, and the sooner they're flexing, at 2 months, they're flexing 135 degrees. They will fail within 12 months. I know maybe this is a comment that's going to get a lot of people very upset, because we are a nation obsessed with flexion ranges. And in most presentations, you'll see a guy squatting on the floor, jumping up, sitting cross-legged on the ground, using Indian toilet type sitting. So these are all, they look great on presentations and on slideshows, but in reality, these knees don't function very well. Maybe that's an extreme example, but that's my buy-in.
So what is your stand on, if your MCL is disrupted during the surgery, you go to a hinge, is what is the comment. What is your take on that?
So again, it depends, Anoop. You don't have to go to a hinge. If it is an acute and you can detect it on the table, you can actually do a repair. And again, there are several articles. You need to brace them for about 6, 8, 10, 12 weeks. If you're unhappy about it, you can reinforce it using the semi-T. That has been described. But if it is a complete disruption, it's a through and through, your saw blade has gone right across, so your knife is actually divided it, those MCLs do not do well. If it's a partial tear, you can put some loop sutures, you can do some mattress sutures, pull it out of the bone, reinforce it with semi-Ts. They do reasonably well. But if it's a complete transection, then you're pretty much in trouble. You should go to a constraint. And my level of constraint then would not be as CCK. I would then go all the way and I'd put in a hinge. Because that would be my one indication intraoperatively for primary where the MCL is completely disrupted, because that disruption goes up to the posterior medial corner. Your semi-T, your semimembranosus is not working, and it's just a progressive failure mechanism.
So for your patients with stiff Varus knees, say from a mild to a severe deformity, would your median release be gradually increasing, or would it do a standard median release for all these patients?
So it would gradually increase, Jay. For a very, very mild, I would just go up to the medial collateral ligament. The deep part, little more deformity, I would go to the posterior edge of the deep MCL. If it's even more, I would go up to the semimembranosus, maybe just the anterior part. If it's even more severe, then I would go to the whole extent of the semimembranosus. Even more, I would release the PES, the anterior fibers of the PES, and the final release, and nothing else works, and you still have this massive deformity, and you're not able to fully correct it. Then I would release the superficial MCL, and we do this in flexion at 90 degrees. Take a long, narrow osteotome. We do it subperiosteally, and as we're releasing it, we gradually extend the knee. So as you extend it, it takes that subperiosteal sleeve along with it. You don't actually divide it. And then you check for stability, and you should be able to get away with it.
And so you do your knees, you do the entire femur first. That's what I noted on the video.
Yeah.
And then to the tibia. And you do the trial with, you check your balances with the trial poly itself.
Right.
At that stage, if you feel that you are probably tight in either flexion or extension space, would you go for a soft tissue release at that stage, or would you think about revising bone cuts at some point?
So if both the flexion and extension spaces are tight, I would take out more tibia. If one or the other, if only my extension space is short, then I would, and I've done all my adequate releases, then I'd take off additional femur, distal femur. If my flexion space is very, very tight, but my extension is all right, then I probably upsized my femur, and then I would downsize the femur. I would take off more bone from the posterior condyle. Yeah.
Sir, I had one question.
Yeah, sure.
So sometimes in a very tight knee, once we have achieved balancing on completely flexing the knee tends to get into slight external rotation, and the tibia tries to subluxate on the medial side in complete flexion in very tight knees. In those cases, sir, what do we do?
We're talking about a varus knee that you have released, and at the end of it, this is what. So, if you, just a couple of quick points. When you do your surgery, don't leave your knee tight. Tight knees are painful knees. They don't move. Okay? So, and there is soft tissue tension. And the patient who is not able to move will be in pain. When they are in pain, they will not move. So it becomes a vicious cycle. So the easiest way to get out of it is if you've done everything right. Like I said, your flexion space is tight, your extension space is tight. You try to flex it, and your tibia component is going into external rotation. That's what you're saying.
Yes, sir.
Increase your release to the posteromedial corner. And if that does not allow you to do get it into full flexion or extension, take an additional 2 millimeters of tibia out. It makes no difference at all. One thing I would say that be very, very careful when you are resecting additional tibia. Because you think you're taking out 2 millimeters, it's actually about 4 millimeters. And then suddenly from not being able to put a 9 millimeters, suddenly you see you need a 14. That happens very frequently. So whenever you do before you start cutting the tibia, so I always believe that the most critical and the most difficult cut is the tibial cut. And the reason I do my femur first is once I've got my femur out of the way, I can actually lift the femur up. I've done my release. I know exactly how much additional tibia I need. I need 21 millimeters between the femur and the tibia and both flanks, or 20 to 22. So you take out 21. And just as a rough, you use a laminar spreader from your posterior condyle of the femur, measure 21 millimeters, make an approximate mark. I mean, when you start, that's the way I did it. So and often you'll see that in these very severe deformities, taking out even 5 millimeters or 4 millimeters of tibia will do it because you've removed the osteophytes, you've removed the soft tissues, and you'll find that you will get a 10 millimeter even in some of these very severe deformities. And of course, as far as the PCL is concerned, entirely your choice. I mean, I am a CR surgeon. There was a time when I used to always say, no, you should do CR. I think that's wrong. You should do what works for you, what you're comfortable with, what you're trained with. And, as you get older, you become more tolerant. So I just think that CR does as well, PS does as well. And whatever works in your hand and you are comfortable doing, you should do that.
Great. So thank you, sir. I guess we will go on to the cases and then we'll discuss as we see more cases and then pinpoint whatever errors or difficulties that the presenters did find in their case. So I call upon Dr. Abhishek Patil to present his case first.
Yeah. Yeah, I'm just trying to share my screen.
So you still use the tourniquet for all cases?
They stopped using tourniquet now.
Right.
I think it makes a huge difference because the patients have stopped complaining of thigh pain.
That's right.
Yeah. The only time we use it is patients have a lot of varicose veins and stuff. They keep bleeding a lot. So in those cases, we exsanguinate. That's very, very few cases. And that also only during the cementation technique.
Is my screen visible?
Not yet. Just go on, click it twice if at all.
One second.
Share content on your desktop. So if you have an intramedullary rod like a PFN 220 mm or maybe 260 mm long PFNs, and you need to do a TKA, so your choice is basically navigation, extramedullary jig, robotics, implant removal first. What would your choice be?
Anoop, you're really putting me in a spot now. So we have a set of instruments that I call the extramedullary. So with implants, we don't actually go into the canal at all. So these are instruments that I developed about 20 odd years ago. I'll be happy to share them with you.
Yeah, sure.
And you can use you can do all your cuts without actually worrying about the implants, unless you have a distal femoral locking plate or DCS or one of those.
That's right.
Am I visible now?
Yeah, you are.
Yes. Yeah.
Okay. So good evening, everyone. Thank you for this opportunity to present my case. I'll be presenting a slightly different case here. It's a case of osteoarthritis in a patient with below knee amputation. So my patient here is a 54-year-old male who had a traumatic knee amputation 20 years ago. Currently, his tibial stump measures around 13 centimeters below the joint line. He is mobilizing with an orthosis, which is partially end-bearing and partially side-bearing at the level of the thigh. He complains of knee pain, which was chronic and mechanical initially, but now since 2 months, he is having significant wrist pain as well. On examination, he has patellofemoral and joint line tenderness, fixed flexion deformity of 15 degrees with further flexion up to 90. The skin condition was relatively good. There was a pressure sore of around 1 centimeter at the tip of the stump with a puckered scar on the lateral aspect. No significant laxity, blood parameters normal, absolutely not responding to any line of conservative management. He had had multiple consultations and was advised to go for an above knee amputation. However, the patient was not willing for the same. So these are the clinical pictures. We can see the scar here and this pressure sore there with a 15-degree deformity, flexion deformity, and that's his further flexion. And these are the X-rays which show tricompartmental arthritis quite significant. So now the question was, of course, being a joint replacement surgeon, of course, this is a natural question which came to us, that is a knee replacement possible here? And we decided to do a literature review. We discussed this amongst our colleagues and we were almost labeled as criminals to do a knee replacement in this case, but we still said, let's go for a literature review. And when you search for the literature out there, you realize that there's not much on this topic. There's very, very limited literature. And this was one of the most cited articles by Karam and Willie et al. From the Iowa Orthopaedic Journal 2010, where they have reviewed 3 case reports. And one of the most controversial topic in this case is how to go for the tibial cut. So we'll discuss, so the options were only 2. One is an intramedullary jig and the other is a customized or a patient-specific jig. There was a lot of controversy on rehab protocols. One author was starting weight bearing at 4 days, whereas the other 2 delaying that for 3 to 6 weeks. And the authors reported that there was a high incidence of total knee arthroplasty in the contralateral limb. The only good thing was that the midterm results were pretty satisfying in all 3 patients. And therefore, the authors suggested that total knee replacement can be considered as an option in end-stage arthritis in such patients. So this is just to highlight the 3 case reports. There was one more case report published from Adelaide by Fleming and Dixon. He was a 64-year-old male who was operated for high tibial osteotomy at the age of 47. There was a nitrogenic popliteal artery injury which resulted in a below-knee amputation. The patient continued to have progressive arthritis over the next 17 years and that needed a TKR. The authors used a customized patient-specific jig based on their CT planning, and they haven't said anything about their rehab protocol. And as on the date of publication, at 8 months, the patient was doing quite well. So finally, this was all that we had, and we decided that, all right, we have some data to back our decision to do a knee replacement in this case. So we decided to do a knee replacement. Of course, a lot of difficulties were expected. What sort of a position to use, what sort of supports to use, will there be an issue with the exposure? We initially felt that we could use a wooden angled frame to assist in exposure, but very early on in the surgery, we realized that that was not going to work. And finally, it was boiled down to the fact that we'll have one assistant lifting the femur continuously and one assistant will be holding the tibial stump and aiding with the exposure. Eversion of patella we thought will be an issue, but it was not. Tibial dislocation, of course, was left to the assistant to give us a good exposure and of the tibia by subluxating the tibia forward. The biggest problem was how to take a tibial cut. Because of budget constraints, PSI was not going to be an option. Navigation was going to be difficult with no references from the ankle. So we decided to go with the conventional way. How to adjust the slope? So we knew that the tibial cut was going to be an issue and taking care of the slope was going to be even more difficult. So we decided to use an implant which requires a 0 slope, which was the Biomed Vanguard. And so that would reduce the burden. Problems with wound healing, yes, of course, we felt that could be an issue. and that's why we decided to go very conservative with our rehab. With respect to infection, so far in the literature, what we reviewed, there was nothing to suggest that there is an increased risk of infection. So nothing with that. And of course, the last thing would be what sort of an orthosis to use. So this is how we had to work around, one assistant holding the femur and the other assistant holding the tibial stump. And we could manage to get a decent exposure. And once the femur cut was taken, that's how, I know sir wouldn't like those spikes around, but we had to use them in this case because we had no lever arm in the lower limb. And we decided to use an intramedullary rod. Now, I understand that for this rod to be useful as a reference, it has to take hold in the diaphysis. And that's how you would get a correct reference. But we felt that some reference is better than no reference. And therefore, we used the rod as much as we could and then attached the tibial jig on top of that. And of course, we were constantly checking with eyeballing whether the cut is proper or not. And once the tibial cut was done, then the rest of the surgery was pretty much standard. That's the final implant in situ, in flexion, and that's the implant in extension. And we could manage to correct the flexion deformity almost completely. So those are the immediate post-op X-rays at post-operatively, and those are the X-rays at 3 months. That is a sort of an orthosis that the patient is using. And that is his walking video. Of course, he's not using his knee optimally because of the very short lever arm of the tibial stump, but he is very comfortable and pain-free. Right now, we have completed 3 years of follow-up and there are no issues whatsoever with respect to either pain or any loosening or lysis. So to summarize, the knee replacement in a below-knee amputee is a documented procedure and can be considered as a feasible option in a motivated patient. Literature is very limited and long-term follow-ups are not available. It needs planning at every step of the surgery. I forgot to mention about the rehab. So we didn't allow the patient any weight bearing for at least for 6 weeks till we were assured that the wound had healed completely and he could then wear an orthosis and go ahead with further rehab. So that was my case. Thank you.
Great. Good case. Very good case. Yeah.
Excellent case, Abhishek.
Is Rajgopal sir still there?
Yeah. So
Yeah. So your comments.
Abhishek,
Yes,
very, very difficult, challenging case. I think you absolutely nailed it. I think very, very impressive.
thank you, sir.
A very, very difficult decision, difficult surgery. I think you handled it very well. Just a couple of points to your planning. I think your choice of implants was very good because Biomet was one of those that does not really need a lot of tibial slope. Your sizing is good, and to your point about using the intramedullary tibial jig, that's absolutely the right way to go about because this is such a short stump that if you had used anything extra articular, it would have been a challenge.
Yeah.
So whatever little hold you got, I think you've done very well. My only suggestion to you is you should write this up.
Yes.
Because I mean, I commend you on your review of literature. There's such little write-up about this, even as a case report.
Yes.
There are these BMJ case reports. I think you must, and you have a 3-year follow-up on this.
Yes.
You should do like a brief review of literature that you presented.
Yes.
And I think you should definitely publish this.
Yes. Thank you, sir. Thank you.
Great case, Abhishek.
Abhishek, I had a suggestion actually.
Yeah.
So, what you can do is you can use a completely metallic, lower limb orthosis, right, which can be autoclaved, and then you attach it like
Yes.
the
Yeah.
lower
Yeah.
part, you attach it like
I understand. I understand.
And with that, actually, you could have used, because it is in alignment with the leg,
Yes.
you could have used an extramedullary jig with
Yes.
that, and and
Could
took
have
a
been
cut.
done. Yeah. In fact,
The intramedullary that you used. So the second thing which a suggestion could have been that when you use an intramedullary, probably use a Shyam to see whether you are going in center in both the planes.
that's a good idea. I agree. That's a good idea. And in fact, even when you're using patient-specific jigs and you need to do a CT scan, the authors do recommend that the patient should do a CT scan with the orthosis on, so that the limb is in proper alignment for the CT cuts and you get a good measurement. Yeah.
So if you use a completely metallic, you can actually use it intra-op also, and then
Autoclavable. I agree. That's a good idea.
It is going to be stable below to handle the leg also.
It'll make it easy. I understand.
Yeah,
definitely. Yeah.
Abhishek, I have a question.
Yes, sir.
What is the status of the other side of the knee? Means the other knee, left knee.
The left knee at the latest follow-up was having grade 1 KL osteoarthritis, but he's walking. He has no major complaints on that now. But as I said in the literature review, that there is a very high incidence of osteoarthritis needing a knee replacement in the contralateral limb as well. And the authors also suggest that if you're going to do a knee replacement in the opposite side, they suggest to use a stem, because there is increased rates of failures and aseptic loosening on the opposite side. So the authors in fact go one step further to suggest that you use a stem on that side.
Excellent.
Great, very nice case, self-explanatory, a good review of literature, I guess. Congratulations. I call upon Dr. Jayesh to present his case next.
Are you able to see my screen?
Yes.
Yeah, we can.
So, good evening, everyone. So I have a case of a 62-year-old female. She has bilateral knee pain since the last 4 years. She has difficulty in squatting, stair climbing, and walking long distances. So her right-sided complaints are more than the left side. So she, at the time of presentation, she had significant medial joint line tenderness. Her range of motion was from 10 to 100 degrees on the right side, 5 to 120 on the left. There was 15-degree varus on the right side and 20-degree varus on the left side. There was not much of a medial lateral laxity, but the anteroposterior laxity, but the medial lateral laxity was that the varus was correctable. So this is the X-ray of the right knee, and this is the X-ray of the left knee. So we did the right knee first. It is showing bone and bone medial joint and arthritis with varus. So what do you think should be the plan now in this case? You want to know something else?
Correct. How much correction is possible? Stress views that.
It was correct.
If you have them.
No, we did not have any stress views.
You have and a scanogram, if at all you have it.
The next step that we did was we took a scanogram, and then we found out that what was not seen on the short films, that the patient has significant femoral bowing. She had more on the left side as compared to the right. So now we knew that now this is going to be challenging in terms of getting our distal femoral cut correct, because if you use a short rod, it is not going to go up to the end, and then you will you'll have difficulty in correcting it with a normal 5 to 6 degree of varus that we calculate. Tim has described a femoral bowing angle, which is this angle. So it is the angle between the proximal diaphysis and the distal diaphysis. So if this angle is around, it's less than 0, then it's fine. But if it's more than 5, then you know that your conventional jigs are not going to work very well in such patients. So then what were the options available? So navigation in such cases is the best option, but it's not readily available with everyone. So now there are 2 ways of handling this. One is an lateralized entry point with a calculated valgus angle, or the second thing was the short rod and an extramedullary guide with a marker placed on the femoral head. So the planning for a lateralized entry point is you calculate the normal femoral valgus angle. Then the yellow line that we see is a line which is just flush with the lateral cortex. So we find out where it is exiting, and the orange line that you see is the diameter of the rod that you have. So now you need to shift the your entry point to half of the diameter of the rod which is there. So this is the point A, which is the normal entry point that we take, and point B is the calculated the calculated distance from the center for the entry of your normal intramedullary jig. So this has been described by Al-Shamimi in this latest paper. The other thing, as I said, is we use extramedullary guides or jigs, which when you place the jig, the rod goes to the center of the hip over here, and you place a marker on the center of the hip. Now, ideally, it is better that you have a radio opaque marker on the center of the hip so that you can check it intraoperatively with the C-arm. This is the way when you have applied the jig, the rod goes to the center of the hip. You check it with the C-arm whether it's there, and then you adjust, and then you pin your distal femoral cutting jig with the rod at the center of the hip, which is what we did in our case. And then these are the post-operative X-rays in which you can see that the alignment is now perfect. And the knee is the distal femoral cut. Now we were able to get it with a short rod. Any questions?
Yeah, Dr. Ashok Rajgopal sir, your comments on femoral bowing. Again, a very good topic to discuss on. So we can't hear you.
Yeah.
You are muted.
No, I'm saying you guys are presenting some wonderful cases, brilliantly decoded. So I think what you've done is exactly the right thing, because if you take the central point on top of the PCL or the intercondylar notch, you're going to perforate the femur. So you take lateral as you've done. Just a sort of a quick point here is, even when you take this lateral entry point, take a 6 millimeter K-nail reamer and just drive it in, and just, you will be able to navigate it through the medullary canal, and that gives you a rough idea of what your distal angle should be. You've done it absolutely right. You've used the extramedullary guide. That's another way to do it. And your post-operative X-rays are. Can I just see your lateral view for a minute?
Just a second, sir. Yes, sir.
Just share your screen first. Yeah.
I've shared. No.
No, we can't see. Yeah.
Yes.
So if I was to critically comment on this, you've restored your AP alignment perfectly. So if I was very, very critical about it, 2 points. One is, I don't know whether it's the X-ray view or whether it is just the appearance. Your slope on the tibia is a little bit excessive. I don't know if that is an apparition because of the of the view.
Yeah, I have actually enlarged that, not
Okay.
the size.
Right.
But there is a definitely sort of excessive slope, slight excessive.
Yeah. And the second point, which I think is a little more relevant, is the size of your femur. You have an oversized femur there. Because if you take the posterior condylar offset, you're about 1, maybe 2 sizes big. So for the kind of problem that you had, I think this is an excellent alignment. The only end result may be that your flexion range may be a little less compared to what the patient would like. And I think you should warn him not to try and force the flexion. But other than that, I think this is an excellent surgery.
So if at all, while we are using intramedullary rods, the long rod does not go in. We just have the short pre-op films. A scanogram is typically not done. In those particular cases, we use a short rod. What would be your take? Does the shorter rod, if we are not able to negotiate a longer rod, we use a shorter one. What do you do? Because your anterior bow on the femoral side can also have a component in flexion.
Yeah. So I know for the longest time, including it even now, of course, now we use the Persona system. Forever, I've only used the short rod.
Okay.
Some of my juniors keep telling me, why don't you use the longer rod? You don't really need to use a very long intramedullary rod, because basically the idea is you're aligning this to the distal diaphysis of the femur. Unless you've got gross extra-articular deformities where the whole sort of philosophy of your alignment changes. For the routine, I mean, this is possibly one of those osteomalacic patients or physiological bowing, anterolateral bowing, which is very, very common in the subcontinent. But otherwise, even using a short stem, which, like I said, I mean, 85% of my knees that I did before we got onto these more sophisticated systems, they were all short stems. They were all short stems. And you can actually play around with that a little bit as well. You can toggle it a little. Yeah.
So then extramedullary alignment rods for re-verification in case we cannot negotiate a longer rod. That's what I was coming to. So how much do we revalidate our shorter rods in case we are not able to negotiate a longer rod? How do we use an extramedullary rod as a precautionary measure? And is imaging a problem, especially while your component or knee is flexed? So CM imaging is also a problem.
Yeah. Honestly, Anoop, I would not validate it with an extra-articular, because extra-articular is so vague. You have no idea where the femoral head is, and you got those drapes there. And even if you put some sort of a marker there, trying to find that marker. So, as I said, try and align it to the distal diaphysis, because ultimately that is your axis along which your and the only thing I would do differently, I don't know what kind of valgus angle you take, but we typically, for a varus knee, we take a 4 degrees valgus, and for a valgus knee, we take a 3 degrees of valgus. So we are pretty, I mean, in a way that is unphysiological, because ideally what these robotic guys say, it has to be customized for each knee. But the basic fundamental principle is, if you go back to what I commented about, all our knees are in varus, if you give these patients a neutral alignment, then those patients are going to be happy. You're not swinging towards the kinematic, which is leaving the knees in varus or leaving the knees in valgus. You give them a basic neutral alignment. In females particularly the obese females who have wide pelvises, if you put them into 5 degrees of valgus, they're going to curse you for the rest of their life, because there's thigh contact, there's knee contact. They're very, very awkward to walk with. So short rods are fine. I don't think you need to worry about it. And as long as they are snug and they're going in snug, which is why the minute you get into problems, my go-to method is I take a 6mm K-nail reamer and just push it in, and make sure that if you can see that at right angles, I think you're in a good space.
Right. Nice take-home points. The case well presented. So should we move on to the last case? Dr. Sameep will present the last case. Can you share your screen?
Yeah, thank you, Anoop and Jay, for inviting me. And it is really an honor for me to be on this platform, and along with friends and colleagues as well. So I'll start the screen, and the way I would like to present this case is a sort of I will be asking some questions after I share the 1 or 2 screens. It will not be an entire full presentation as Abhishek has done. So I like to take the permission for that.
Yeah, sure, go ahead.
Is my screen visible?
Yeah.
Yes.
Yes.
Yeah. So this case is of a 62-year-old elderly lady, and she came to me with a trivial fall with a left knee pain. And she came to the casualty. She was on a wheelchair, and prior to the fall, she was walking almost normal. So these are the X-rays. The left knee is the one which is was the affected knee. So she had pain on the left knee. So anything you would like to comment, Jayesh? Abhishek?
Is there a fracture of the lateral proximal tibia just below the condyle?
No.
It's very difficult to comment here. Probably
The X-ray is not
Undisplaced.
absolutely
Tibia
clear.
fracture.
it's very difficult.
Undisplaced
Yeah.
tibia fibula fracture.
Yeah.
And
Now I can
condyle.
see that.
It's basically a fracture of the tibia. It is almost like a undisplaced fracture.
Yeah, it's not visible.
Fibula
on the
is not
AP.
fractured actually. Fibula is not fractured. It's only the tibia which is fractured.
Yeah, it's visible more on the lateral view, not
Yeah,
so
yeah.
much on the.
Initially. So any investigations you would like to ask, more investigations? Would you like to do an MRI?
I'd like to do a proper clean X-ray actually
So
more.
the X-ray is good actually. I have taken the photo from the screen. That is why it is pixelated. X-ray is obvious there is a fracture.
Question is whether she had any symptoms prior to this fall and what kind of fall it was, whether a trivial fall or a
It was a trivial fall.
Did she have any symptoms prior to the injury?
She is having knee pain since 3 years, and she was actually limping for a while, means maybe 2-3 months.
I mean, this is a stress fracture. She has severe varus deformity. She is obviously there is a varus thrust. I don't know what her weight is, but this is a typical stress fracture. It's a fatigue fracture. She's had a trivial trip or jerk or whatever she had, and it's given way. That's really the sort of anatomy to this fracture.
So even, sir, I concluded that it is a stress fracture. After taking the history, it was pretty clear. So now the thought came to my mind is whether I should be fixing this fracture, whether to use a sort of a MIPO technique to fix it, use an intramedullary nail, or should I use a long stem TKR?
So,
and what is the sort of the thought process behind the decision?
So if it's a stress fracture, unless we correct the deformity and relieve the stress, it's not going to work. So my option would definitely be doing a replacement, and depending on the length of the fracture from the tibial plateau, what sort of a, yeah, so I think we can negotiate this with a long stem.
Anoop?
Yeah, so long stem TKR, I would rather prefer to use an IM jig as well, if you have it, and use a long stem.
I would actually, if I know that she is going to require a total knee, and this is since the completely undisplaced fracture, I would actually cast her, let the fracture heal, and then do a normal total knee rather than subjecting her to a long stem and a bigger surgery.
These kind of fractures tend to maybe not heal too well at times because they have gone into a fatigue failure, and because the fibula is probably intact, we're not very sure. I don't know, maybe a long stem TKR would probably be the best option.
I was actually in the mind of doing a TKR for her because from her history she was obviously quite bothered with the osteoarthritis as well. So I decided to do a total knee replacement. And intra-op, I found that the fracture was very unstable. It was quite a tricky situation because one assistant had to come. It was sort of the apex anterior it was sort of moving on in all two planes, and one
Oh,
assistant had
oh, one sec. Dr. Sameep, was fibula also fractured?
no, fibula was not fractured. On the X-ray, it's quite clear. But it was that the tibia was quite unstable because it's acute fracture,
Okay.
and
Okay.
the long stem, only the uncemented long, that much long, you could get the hold on the uncemented side, and rest of the surgery went off uneventful. I mobilized her partial weight bearing with a long knee brace, and the post-op, actually I was quite happy.
Do you think you could have put a little longer,
Right.
stouter stem maybe?
Actually, what happened is that the diaphyseal, the AP as well as lateral, I could not get more than this, because I was actually worried that if I put a slightly one size bigger, I might shatter the diaphysis. So I sort of went the easy way. Means I did not struggle too much on the sizing. I took the easier option and I just bypassed it.
So Sameep, this is a good job. I think what you did is the right thing. Just a tip, in case you ever find that you're, like you mentioned, that the fracture was very unstable, the easiest way is take one of these little plates, put a unicortical screw. It'll stabilize it. You'll allow your reamers to go through. And once your reamer is in place, stem this long has always, there's only way to use it, and that is uncemented. You should never ever cement these long stems. You do a metaphyseal fixation, do a good surface fixation of your tibial base plate. I think you've done a great job. That's wonderful. And they will heal very quickly. You can actually make them fully load these joints, within 24, 36, 48 hours of surgery. It's a compressive force. The more you make them walk, the quicker this bone will heal.
Sir, this is the 1 month post-op X-ray. Already you can see the callus, exuberant callus on the fracture site. Only thing I was worried is it too unstable an entity? Whether I should have added a plate along with this.
No, I don't think you should have used a plate, Sameep, but I would agree with the earlier comment. I think you could have gone one size up on this nail. I think that stem is a little short, and that is why it is, you have about, I think, 2 inches of distal diaphyseal fixation. And if it is not a snug fixation, so again, just as a tip, take a intramedullary reamer, take a power reamer, go through, and the reamer size which stabilizes your diaphysis, and you can actually hold it in your hand and lift the whole tibia up. So you have a cortical purchase. So that is your size. So if you're using, let's say, a 12, and 12 is going easily, you put a 12.5, and then that's going easily. You put a 13, and 13 you get a good grip, and you can actually lift the leg off the table with the end of the reamer. That's your size. That is your interference fit. So I would take a 13 stem, and because your reamer has gone in, you'll actually have to bang it in. And as you bang it in, you'll find that this fracture will gradually come together. It's like one of those AO principles, it sort of compresses it because of its 3-point fixation. And once you've got that, you can actually mobilize. But I don't think you need to worry about this. You're already seeing callus. So this is the core concept of rigid internal fixation versus biological internal fixation that the AO guys have been fighting and talking about forever. This will heal very well. Yeah, excellent. See, to the point about your nail size, you see the periosteal reaction at the tip of your stem.
Yes.
It's a little loose, which is why it has allowed for that movement to happen. But that's a great result. I don't think this patient will have any problems.
Thank you. Thank you, sir.
So at the previous X-ray stage, when at this stage, would you think of giving more of a brace or something at this point because you're worried it's a little loose in the canal?
Not really. I mean, you're one size down, because if you see the tip, you're all right on the AP. You're all right on the lateral view. You see there is a little bit more that could have gone. So it would have been a snug fit. That is why using a reamer would have given you the absolutely accurate idea of exactly what the size should have been. But this is great. I mean, these are very difficult problems. They look easy, but they are very, very difficult. You have to deal with the arthritis, the alignment, the fixation, deciding on the right size. And sometimes I think maybe being undersized a little bit is not such a bad idea, because you have a great callus. The only downside is you have a stress riser right at the bottom, at the tip of your canal on the lateral side. But I don't think there is anything to worry about. You have got good fixation, and this lady should do well.
So when you do such a case, do you ever touch the fibula? Because it's not fractured.
No.
Ever think of doing a corticotomy or?
No, because it is a stress fracture, because it's an insufficiency fracture. They will heal. They'll always heal. They just need a stable upstairs. You correct the deformity upstairs in the tibia, in the knee joint. You take away that varus thrust, and you're fine. The minute you do that, this will heal. Even if this was one size less in terms of the nail, you would still have had this sort of a side movement. You would have had, the callus would have been even more.
So when
only criticism may be that, like I said, you're one size down on the femur and on the tibial nail, intramedullary stem, but otherwise this is perfect. This is absolutely fine.
And so we have seen. I mean, I've seen a few patients. I mean, a couple of them, which have this kind of a wiper effect, and it's almost like a pedestal, and it leads to distal tibial diaphyseal ectasia. And you don't know what to do about them. I mean, do you completely revise them? You see that progressively over a period of 6 months, you see that the stem moving out when the stress fracture is healed. In spite of that,
yeah, if you're seeing that, then that stem is loose, then your implant is loose. Because once it is stabilized, I would follow this X-ray, but the very fact that he or she has shown this stress reaction, it means it has reached a position of stability. So if after 6 months from whenever this X-ray was taken at 3 months, you see further shift, then clearly that tibia is loose. But otherwise, I think this has reached a position of stability.
So this patient actually is doing well. I don't have the X-ray because she's not in India right now, probably because of COVID.
Like I said, I think she has reached a position of stability. I think you can forget about her and tell her to stay wherever she is, not come back to India.
I had a question. If this fracture was probably slightly more proximal, because this is more of a diaphyseal fracture. So if this fracture was slightly more proximal, then it would have been very difficult for any of the rod to get a hold at that fracture, and then this distal part of the tibia toggling would still be there. So in those cases, sir, do you need to add some extra stability or no?
No. In fact, to the contrary, the more proximal it is, the easier it is to get the rod through. You get a much better purchase distally. You'll get a much better distal purchase. So that should not be a problem.
And so for these patients, I mean, I'm presuming it goes without saying that they need to be managed with drugs also medically, because it's probably a fatigue fracture. So we need to figure out whether there's osteoporosis and deal with that concomitant with this.
Yeah, you need to get that whole calcium metabolism chain investigated and so on, and get them sorted out, put them on some sort of alendronates or vitamin D or some such thing, and hopefully that'll take care of them. Great cases, all three of them, wonderful. Very, very interesting and very competently dealt with.
Thank you, sir. Thank you, sir.
Thank you so much, sir.
No, it's been a pleasure, and thank you all for having me as part of the group. It's been a wonderful evening, and compliments to everybody who operated these difficult cases. Some learning for all of us, I think, and look forward to more. This is definitely not a young scientist. This is the work of some very mature, very intelligent surgeons. So full marks and kudos to each one of you.
Thank you, sir.
Right. So all the best. Have a great evening, and
Thank you, sir.
look forward to the next time.
Yes,
Thank you, sir. Thank you.
Really appreciate your time, patience, and your expertise, your comments. Many things to learn from. I guess Dr. Jay will also agree. We had a fabulous time, an academic feast.
Thank you, Anoop. It's been a pleasure. Like I say, I learn as much as you guys do, because you have interactions, you exchange ideas. It's always stimulating, and it's always a pleasure. We all learn from each other, and that's the only way to go ahead. So keep doing the good work, stay safe, stay away from all this horrible thing called Corona, and hopefully see you again in a few days, weeks, months, whenever. Right?
Yes, sir.
Surely, sir.
Thank you
All
so
the
much.
All the
Thank
best.
you, sir.
God
Thank
bless.
you, sir.
Take care.
Yeah.
Yeah.
Thank you, Abhishek. Thank you, Dr. Jayesh and Dr. Sameep.
Thank you, sir. Thank you for the opportunity.
Very nice cases.
Close the meeting.
Yeah, we'll close our meeting.
Yes. Thank you very much.
Thank you. Thank you. Yeah, sure.
Nice to see Jayesh and Abhishek also after a long time.
So nice to see you. You're looking absolutely the same.
Exactly.
You can still qualify to become a resident in KM.
Arey baba, nahi.
Neeraj sir, are we still live?
Can we stop the recording?
Yeah.
Yes.
Okay, you're doing masti online, huh? Okay, Dr. Ashok Shyam sir, can we stop recording?
We are still live.
Very nice cases, huh?
Yes.
It's quite interesting.
Nice mix of cases. Means we did not know what the other person is going to present, and turned out otherwise it can happen that it is the same.
Similar case, yeah,
Can be
very
the
true.
same way. But
Very
turned
true.
out quite a nice mix of cases.
All right.
Abhishek ची भारी होती है case.
Abhishek, add that metallic processes part in your if you write
Paper.
it up, add that this could have been done.
Yeah, that will be a part of the discussion, I think. Yes.
We saw that small little hole in the tibial shaft. Did he use some Stingman pin?
No. That was, he probably had a compound fracture. Probably there was an external fixator or something, and that was that. Yeah.
Nice, good job.
Good.
Okay.
Yes.
Thank you.
Have a good day.
Bye.
Have a good day, all of
We'll
you.
meet in person. Yeah, thanks.
Yes, very soon.
Pleasure
Chalo,
to have you.
take care.
Bye bye.
Bye bye.
Take care. Bye.